Today, I'm very honored to welcome Dr. Laurence Huang. Dr. Laurence Huang is a professor of medicine in the Division of HIV/ID and Global Medicine. Dr. Huang is also the chief of the HIV/AIDS Chest Clinic at Ward 86. And Dr. Huang's research focuses on people living with HIV who have pulmonary disease. And he did this talk for us last year, and it was fantastic. So he's here to share pulmonary cases and people living with HIV. His title of his talk is Help, I'm Short of Breath, Complex Pulmonary Cases in People with HIV. So thank you so much, Dr. Huang.
Do we need this here? Thanks for the opportunity to speak today. I don't think I gave myself that title, but I kind of like it, so we'll just go with it. In any case, outside of NIH grant funding, I have no relevant financial disclosures. And as I often forget at the end, I put this at the beginning, I want to acknowledge I will mostly talk about clinical care, but at the end, sort of indicative of the duality of my career as both a clinician as well as a researcher, I will talk about some research studies, and I just want to acknowledge the San Francisco research team that contributed to this work. So hopefully you have the audience response app already. I'm going to do a warm-up question. It's more for my own interest as well, which is, how long have you practiced HIV medicine? So question A, since the 1980s, B, or answer B, the 1990s, C, starting in the first decade of the 2000s, D, from 2010 to the present, and then E, I am not a healthcare provider, or I'm just here for free breakfast. And you might be able to see the Huang Lab Halloween t-shirt from last year, which is that we were just there for the booze, BOOS. So let's see what we got here. Uh-oh. Okay. All right. So a raise of hands. A, who's been practicing since the 1980s? 0 people in the room. Okay. 1990s? 0 people in the room. First decade of the 2000s? 1, 2-ish, 1.5 hands. Since 2010? Couple of hands. And who is just here for the free breakfast? Oh no, most people are here for the free breakfast. All right, that was a warm-up question. So these are cases from my HIV/AIDS chest clinic on Ward 86, which I started in July of 1995. They're meant to be interactive, so we'll see how that goes. We'll do a show of hands. Where relevant, I provide some clinical and management pearls, try to stick with evidence-based from professional societies or international guidelines. But occasionally when there's an evidence-free zone, I'm going to give you my opinion, and I'll note it when it's my opinion. And then towards the end, I'm going to talk about some new pulmonary concepts that are of clinical relevance that come from our I Am Old, and then the renewal is called I Am Olda study. All right, so case 1 is going to be an extended case. This is a 54-year-old man who was referred to me in the HIV/AIDS chest clinic with chronic shortness of breath for the past 1 year. The patient's HIV positive, has a CD4 cell count of 138, percentage of 4%, and a viral load that was less than 30, is on a stable antiretroviral therapy regimen. His past medical history is notable for pneumocystis pneumonia, coronary artery disease, and he's had an ST elevation myocardial infarction, a STEMI, in the past. He also has a history of alcoholic cirrhosis. He reports that he's a former cigarette smoker as well as a methamphetamine user. In terms of his cigarette history, he has 15 pack years of smoking, and he quit 15 years ago. Methamphetamine he used for 10 years, and he quit 4 years ago. On his initial exam, he's not tachypnic with a respiratory rate of 14. His oxygen saturation is 95% on room air, and his exam is notable for a systolic murmur, but his lungs are clear. He's got an excellent primary care provider who obtained some key tests prior to his referral. But the first audience response question is, which test would you order first? And I listed them alphabetically. See if the audience response works now. If not, we'll do show of hands. Not working? Okay. So show of hands, who would order a chest computed tomograph or CT first? No hands. Chest radiograph first. One or two hands. Full pulmonary function tests. Two or three hands. Spirometry. Other. Okay, so some people are not voting, or a lot of people are not voting, which is fine. You could probably order any or all of these tests depending on the circumstance. I think the chronicity of his complaints really argue against the presence of an opportunistic infection. But in any case, he actually had a chest radiograph first because that's the thing you can get basically right away. So here's his chest radiograph prior to him coming to see me. Let me give you a second just to take a look at it. But he's got a frontal and a lateral chest X-ray. So the second audience response question is, what is the most likely diagnosis based on the clinical presentation in the chest radiograph? And for you who have short memories, I put down the prior slide with his history of present illness and his past medical history. So I guess again, well, I'll do it this way because I think it's easier to see. So who thinks that this history and chest X-ray is consistent with A, chronic bronchitis? No hands. B, emphysema? Few hands. C, pneumocystis pneumonia, PCP? Maybe one hand. Tuberculosis, TB? No hands. Other. Okay, so people are shy. Not too many people are voting. The X-ray is basically interpreted as normal. And so any and all of these diseases can present with a normal chest X-ray. The negative predictive value is pretty helpful in ruling out some major pulmonary conditions. Something like bacterial pneumonia, you're really expecting to see focal consolidation on the chest radiograph. Bacterial pneumonia really wouldn't fit with the clinical picture of a year of chronic complaints. Lung cancer is a disease that could fit in with a year of chronic complaints, but if somebody's having complaints for that long, you're really expecting to see something along the lines of a mass, not even like a solitary pulmonary nodule, but something pretty big to be causing respiratory complaints. So the fact that he's got a normal chest radiograph really rules out those conditions. So as I said, all of the conditions that I gave you can present with a normal chest X-ray. So pneumocystis can present with a normal X-ray. Pulmonary tuberculosis can, or TB can present with a normal X-ray and have extra pulmonary disease. But a normal chest X-ray cannot diagnose any of these diseases. And so you really need more testing. So now that you've ordered the chest radiograph, partly from expediency, because you could get it that day, which test would you order next? Show of hands. A, CT scan, one or two hands. B, full pulmonary function tests, 5 or 6 hands. C, spirometry. Interestingly, nobody. That would potentially be the current COPD guideline recommendation. D, sputum for TB and PCP. All right, I already told you that's probably unlikely. And E, other. So the patient had full PFTs before they came to see us, which is always very helpful when you have some key diagnostic tests before the patient arrives at your door, because then you can do a better job of integrating what the etiology is or potential etiology is of the shortness of breath. So this was super helpful. I'm not going to go over the individual components of the PFTs now, but I'll just let you take a gander at it so you can sort of soak it in, and then I'll go through some of the key points in subsequent slides. So just a little bit of background terminology. When I refer to full PFTs, I'm really referring to spirometry, which can be done without or more typically with and without bronchodilator therapy. So 2 puffs of albuterol through a spacer device. And the main features you're looking for with spirometry are the flow volume loop, the forced expiratory volume in 1 second, or FEV1, the forced vital capacity, or FVC, and the ratio, the FEV1 to FVC. You're also looking for lung volumes, and mainly in terms of lung volumes, looking at the total lung capacity, but also the residual volume and the ratio RV to TLC. And lastly, you're looking for the diffusing capacity for carbon monoxide, or DLCO for short, which is often corrected for hemoglobin. For our research studies, we also corrected for carboxyhemoglobin, and the DLCO is often interpreted in context of the alveolar volume, or VA for short. There are other pulmonary function tests which we can do in the PFT lab. Those include MIPS, MEPS, and the MVV. Those are really specialty tests, and I think for the most part, primary care providers, if you're thinking of ordering these tests, you should probably consider a pulmonary referral. So my personal opinion is, for somebody with HIV, I always order full PFTs the first time I'm evaluating somebody with some undiagnosed chronic respiratory condition. And that's both for practical values, because those of you who are clinicians here know that it's often a several week or month wait for PFTs. You don't want to have to do them twice when the spirometry is less than diagnostic, as well as for clinical reasons, which I'll discuss at the end of my talk. So PFT interpretations have undergone dramatic changes. I would say, since I was a fellow in 1992, for about 30 years, really not too dramatic a change in terms of our knowledge base for PFTs. But in 2022, the American Thoracic Society, ATS, and the European Respiratory Society, ERS, updated their prior guidelines, which were in 2005, in terms of how you interpret PFTs. One key point that I want to point out for individuals who are less familiar with PFTs is, unlike many tests in medicine where there's a single cutoff for normal or abnormal that refers to all individuals undergoing that test, so whether you're a man or a woman, male or female, whether you're old or young, whether you're short or tall, whether you're white or black or other, there's one set of cutoffs. That is not the case for PFTs. So the appropriate interpretation of PFTs involves the classification of the observed values as within or outside the normal range that's based on comparison to a reference population of healthy individuals who underwent PFTs. So that's the key point. We compare it to you. All right. Here's a summary of the key differences from 2005 to 2022. Currently, it's recommended that the reference population that's used is the Global Lung Initiative, or GLI reference population. That's a change from the old guidelines where the NHANES 3 had been recommended in the United States. As many of you are aware, the NHANES is a US population. So in the United States, it made sense to look at people in the US who underwent PFTs in the NHANES 3. Currently, we use GLI in the US, not NHANES 3. Furthermore, if you look at the GLI, there's different options for you to pick. You can use GLI race, where it adjusts for the patient's self-identified race. You can use GLI other, which is sort of a mix of individuals, or you can use GLI global, which is sort of a mathematical weighting based on global populations, not necessarily people who contributed to the cohort. And the current recommendation is to use GLI global. There's a movement to remove race and ethnicity from the interpretation. And in addition, we use the lower and upper limit of normal, defined as the lower 5th percentile and above the 95th percentile, to define individuals who are abnormally low, less than the LLN, or high, above the upper limit of normal. And then there's also, when you see the interpretations now, there's more of an understanding that these are not necessarily diagnostic, but they kind of point you in a direction. And so just like the radiologist, you don't see the patient, the pulmonologists now are going to suggest things like clinical correlation is recommended. That's sort of a famous radiologic term. And the last point that I'll make is that there's a recommendation to use Z-scores to classify disease severity rather than a percent predicted. So what the individual is as a percentage of what the global population is. Okay, so now I'm going to break down this individual's PFTs. So the flow volume loop is one of the first things that we look at. Flow is along the y-axis. Volume is along the x-axis. The curve, or the limb that's above the x-axis, is the expiratory limb. So that's them blowing out. The curve below the x-axis is the inspiratory limb. That's them blowing in. And you basically make a visual assessment of, does the flow volume curve approximate normal, or does it look abnormal in a certain pattern? I'm not going to give away the answer, because next question is, based on this flow volume loop, Is it normal? Show of hands. Does it show airflow obstruction? Show of hands. Spirometric restriction or restriction? Show of hands. It's a mixed obstructive restrictive pattern. Show of hands, all right. And then does it show stenosis? It could be intrathoracic, extrathoracic, both variable, or a fixed stenosis. Show of hands. Okay, so most people were voting for obstruction. A few people voted for restriction. This is a classic flow volume loop for airflow obstruction. The top panel would show sort of a normal shape of a flow volume loop. The expiratory limb is more or less a straight line during exhalation, more or less at a 45-degree angle. What you can see in the bottom panel where it shows obstruction is the normal flow volume loop would be the red dashed line, and then you can see the blue line is what the patient actually did. And for every volume, every point along the x-axis, the flow, the expiratory flow, is less than what we would expect because it's below the red dashed line. So this is a classic picture for airflow obstruction. Airflow obstruction doesn't establish a diagnosis. I'm not going to go over this, but you can see that there are different flow volume loop patterns that you can detect or get a hint at. But the real thing that we're looking for then is spirometry. So because this is an older patient, this is the older way that the hospital printed it out. But just so you get a sense of it, you have the FVC, the FEV1 in liters. The ratio is a percent of those two things. The first column you see is the reference value. That would be, in this case, the NHANES 3, what the reference would tell us for this individual's sex, age, and height. The confidence interval is sort of the band for that reference population. The third column, pre-measure, is the pre-bronchodilator, the patient's best effort of at least 3 measurements we would list. And then the last column in that first section is what percent predicted that best measurement was of the predicted reference value. So if you look at the FEV1, we would predict the individual to have a FEV1 of 3.72 liters based on their sex, age, and height. And then this individual, the best they could do was 1.77 liters in the first second, and that was 48% of predicted, okay? The second set of measurements is after the administration of albuterol meter dose inhaler through a spacer. And then the last column is what percent change they were pre to post. Did they get better and by what percentage? So the patient improved by 8%. When you look at lung volumes, it's sort of the same setup. The first 2 columns are the reference and then the range. The third and fourth column is what the actual measurement was and what percent they were of the predicted value. So you can see, for example, the RV is 157% of predicted. And then the same thing for the DLCO. The first 2 columns are the reference and then the range. The third and fourth column is the measured value and what percent the measured value was of predicted. Okay, so now I'm going to put the whole PFT back together. I'm going to ask you to look and tell me, what is the most likely diagnosis? And so Annie's putting her glasses on. Is it really that hard to read? The easy way to do it, even if you're far back in the room and you can't quite see it, is that the lab puts the abnormal values in red as opposed to black. So hopefully you're not red, green, colorblind. And it also puts 2 asterisks next to the things that are abnormal. And so you can see the spirometry is abnormal, the lung volumes are abnormal, and the diffusing capacity is abnormal. So something is abnormal for all 3 of them. So is this flow volume loop and PFTs indicative of A, asthma? Show of hands. Maybe 1 hand. B, chronic bronchitis. Show of hands. C, emphysema. Couple, oh yeah, all right. Couple hands. D, ISO-DLCO, whatever that stands for. Show of hands. E, prism, whatever that stands for. So these are all terminology for pulmonary diseases. Okay, so a lot of you didn't vote. I think maybe because a lot of you are not clinicians and you're like, I don't know what this is. So I'm going to try to give you a little bit of a primer in terms of how we interpret these things. Let's see if this works. Yeah. So this is from the 2022 guidelines published by the ERS and ATS in terms of how we interpret PFTs. So the first thing that we're supposed to look at is the FEV1 FVC ratio. And the question, if you can't see the slide well enough, is the ratio above the 5th percentile, right? So is it normal, right? And then you can see that the ratio is 41%. It's red and it's got double asterisks. So no, it's not normal, it's abnormal. So you go this way. You then look at whether the FVC is normal. It's greater than the 5th percentile. So it's greater than the LLN. You see it's in black, all right? And so you're like, oh yes, it is normal. And so based on spirometry, your preliminary conclusion is this is airflow obstruction. So it's consistent with the flow volume loop. You then go on to lung volumes, same idea, except they kind of flip the question. So now the question is the TLC less than the 5th percentile? So less than the LLN. So meaning, is it abnormal? No, it's 112%. That's normal. Is it abnormally high? So this is abnormally low. No. Abnormally high. No. Right. And then is the RV to TLC ratio greater than the 95th percentile? So is it abnormally high? And you're like, it's 157% predicted, right? And so it's actually abnormally high with red and double asterisk. And so now you're at, this is hyperinflation. And one of the new things in the GOLD guideline that we've appreciated is that hyperinflation is now known to be a significant contributor to shortness of breath. So the patient is hyperinflated. They have airflow obstruction, and they're also air trapping with hyperinflation. The last thing is the DLCO. Question is the DLCO less than the LLN? So abnormally low. And you see that, wow, 48% predicted. So yes. Is the alveolar volume normal? Yes. And so then this gives you a series of diagnoses, including pulmonary vascular disease, emphysema, anemia. Those are all things that can cause this. Putting it all together then with the flow volume loop, the abnormal spirometry that shows airflow obstruction, the lung volume showing hyperinflation, this is going to be emphysema. Those other things wouldn't give you those other patterns. And so that's one of the reasons why I would always get full PFTs, because it gives you a fuller understanding of what's going on. Okay, so COPD, as we know, it's one of the more common conditions in the world. It's the 3rd leading cause of mortality worldwide. It's the most prevalent pulmonary condition in people with HIV in the United States. And people with HIV have a higher prevalence of COPD compared to individuals without HIV. And that's independent of cigarette smoking, because many of us know that individuals with HIV tend to smoke on a population basis more frequently than those without HIV. Okay. Unfortunately, there are no HIV-specific guidelines for diagnosis of COPD. It's thought, and we've typically written in our reviews, that the diagnosis is, in quotations, identical to non-HIV infected individuals. Having said that, the current guidelines for non-HIV COPD really refer to using spirometry with and without bronchodilators, whereas I already told you that I would typically get full PFTs. Oh, sorry, I'm going to stop. Yeah. So I'm going to ask a question right here. I didn't put it as an audience response question, but I've told you now that this individual has COPD. Show of hands. Who would treat this person with albuterol metered-dose inhaler on a PRN basis? It's an option in the GOLD guidelines. Who would treat the patient with a single bronchodilator, either a long-acting muscarinic antagonist, a LAMA for short, or a long-acting beta agonist, or a LABA for short? One or two hands? Two hands. Who would treat the patient with 2 agents, a LAMA and a LABA? 1 or 3, 4, 5, 6 hands. Who would treat the patient with triple therapy? So a LAMA, a LABA, and an inhaled corticosteroid? Nobody. And who would treat the patient with something else? Nobody. So the real answer is I didn't give you enough information to know yet. Okay? You need a little bit more information. And so here are the GOLD guidelines. They come out every year. And there are changes. So prior to this, the GOLD guidelines had 4 groups, A, B, C, and D. The current guidelines, they've now collapsed C and D into E. So there's A, B, and E. If you were just reading this for the first time, you're like, that's kind of strange. But that's the reason why C and D collapse into E. And the basic GOLD guidelines say that to determine what the first line therapy should be or what your first management decision should be, you need to know 3 different things. You need to know whether the individual has been hospitalized in the last year or has had 2 or more COPD exacerbations. Yes, no. And you need to know what their MMRC dyspnea score is and their COPD assessment test or CAT score is. And then based on those 3 bits of information, you can put them in one of these 3 boxes, and then you can decide based on that which is the appropriate therapy as the first try, right? It's an iterative process, so you're often modifying it, but to start them on therapy. So I'm not going to go over this, but this is the MMRC scale. It's a single questionnaire that they give the best answer from 0 to 4. This is the COPD assessment test or CAT. It's 8 separate questions. Each question you can score from 0 to 5. Total up the scores from those 8 questions, and that's the CAT score. And so we did that in clinic. So the patient says that he has had no COPD exacerbations in his lifetime. His MMRC is 4, so that higher is worse. And his CAT score was 26. And so based on these things, the first question puts him in the bottom here. The MMRC and the CAT put him in group B. And so we started the individual on a LAMA and a LABA, as well as a rescue inhaler. So albuterol, MDI, PRN. Comes back to see us. It's like, boss, still short of breath. We're like, he's had an MI in the past. He may have cardiac disease. He may have pulmonary hypertension. And so we ordered an echo. Echo was relatively unremarkable. I'm not saying it's not relatively unremarkable. We were looking for pulmonary hypertension. There's no evidence of pulmonary hypertension, but there is maybe some LV dysfunction, presumably as a result of his MI. Still short of breath. So we order a CT scan. Just because you have emphysema doesn't mean you can't have more than one thing going on. So we get a chest CT scan. I show you a representative image, and it basically shows he's got mild bronchial wall thickening. Not really sure what to make of that because he quit smoking 15 years ago, if I'm remembering correctly. And he has diffusely hyperinflated lungs, which we already knew from his PFTs. So we're like, there's no obvious evidence of like an interstitial lung disease, for example. Still short of breath on exertion. So the next time he's in clinic, do vital signs. His vital signs are notable for a normal O2 sat, 93% on room air. But Nathan, who's my CRC and shadows me in clinic, a future doctor, it's like, okay, boss, let me take him for a 6-minute walk test. And basically, at 2 minutes, he desatted from 93% at rest to 87% on ambulation. And then 2 minutes, 44 seconds, I get Nathan stopped it. His sat was now 85%. So consistent with his complaints of exertional dyspnea, he has significant oxygen desaturation on ambulation. So the individual is prescribed supplemental to starting at 2 liters per minute via a nasal cannula during exercise. He's fine at rest, but when he exercises, he's short of breath. We give him oxygen for a shortness of breath. Individuals who desat during exertion are at high risk for desaturating at night when they're sleeping, because you tend to hypoventilate when you're asleep, and you're also at a mechanical disadvantage when you're sleeping, assuming that you sleep supine rather than upright in terms of where the diaphragm is. So we had to order overnight oximetry. It was done through his medical supplier. Here's his oxygen saturation overnight. 90% would be kind of like an okay O2 sat, and you can basically see for most of the night, his sat is below 90%. Here's sort of the summary, and then the bottom line, which partly got cut off, is that for 498 minutes and 43 seconds, he had an O2 sat less than or equal to 88%, right? So he needs oxygen at night as well. Now, most of you are familiar with the criteria for supplemental O2. Typically, if you're going to get an ABG, you need a PaO2 with, that's less than or equal to 55 millimeters of mercury, or you can do an O2 sat in clinic, which has to be 88% or less to qualify at rest. If you're going to do an ambulatory O2 sat like we did, if the patient needs, I'm trying to read this off sideways. If the patient is not hypoxic at rest, but desaturates during exercise, so the second green bullet that we have, generally you prescribe oxygen only at exercise, versus if they're hypoxemic at rest, you provide oxygen for at least 18 to 24 hours. And then for people who desaturate during exercise, as I said, you should measure it during sleep. And those who desaturate during sleep need a sleep test to look for obstructive sleep apnea, which could be another cause for nocturnal desaturations. And so he underwent a sleep study, which was positive. And so we gave him CPAP as well as supplemental oxygen at night. Okay. Long-term oxygen has significant benefits. There are 2 randomized clinical trials, one in the US, one in Europe, in England, that showed that long-term oxygen therapy improves survival among individuals who use it. You need to use it for at least 15 or 16 hours a day, if not longer. If you only use it kind of as needed, you're not going to get the survival benefit. However, there are other trials in the literature that fail to show a significant mortality difference. Digging deeper into the trials, it appears that these individuals may have had less severe hypoxemia, and so that's why the guidelines are the way they are. So if they're prescribed for individuals who don't meet the criteria on the prior slide, they're not necessarily going to see a mortality benefit, probably because their mortality is not going to be super high. Not to say that it's not high, but super high. But there are other benefits of supplemental oxygen. I just list them here. I think I'm looking at my time. I know we started a little bit late, but I'm going to try to finish on time. There's a lot of other benefits for getting oxygen if you need it, in terms of survival, exercise capacity, cognitive function, quality of life, so on and so forth. Okay, so I'm going to switch to my second case. This is another patient in our chest clinic, 76 years old, referred for dyspnea on exertion that's been slowly progressive over the last 3 to 5 years. Patient is HIV positive, has a CD4 cell count that is over 500, undetectable viral load on stable antiretroviral therapy. Comes to us with a known diagnosis of OSA, so he's obese, but he's had no AIDS-associated opportunistic infections. Former smoker, quit 10 years ago. Lung exam, really pretty unremarkable except for some mild lower extremity edema. To boil down his PFTs to basically, he had a normal flow volume loop, normal spirometry, normal lung volumes, but a DLCO corrected for hemoglobin that was less than the lower limit of normal, and it would be classified as moderately decreased DLCO with a normal ratio. Okay, my last audience response question. So with that presentation and those PFTs, most likely diagnosis, A, asthma, B, chronic bronchitis, C, emphysema, D, this ISO-DLCO, whatever that is, E, prism. All right. So the right answer is ISO-DLCO. So this is a term that I made up. If somebody has their phone out, they can Google ISO downward arrow DLCO. I think like the first 10 or 15 things, I did this last night, that come up are our review articles and our papers. Okay, so this is not a widely recognized term. If you use this outside of San Francisco General, people are going to be like, what are you talking about? But I wanted to make up my own medical term, and so I did. Basically, the description is that this is somebody who has a decreased diffusing capacity in the presence of normal spirometry. So the FEV1, FEC ratio, FEV1, FEC, all normal, above the lower limit of normal, okay? In people without HIV, this is reported to be an extremely infrequent PFT finding, okay? In people without lung disease, extremely infrequent finding, okay? Why did I do this? Well, part of it was because I knew that diffusion abnormalities are more common in people with HIV than those without. So some suggestion that maybe this is an HIV specific or enhanced lung function abnormality. I also knew that diffusion abnormalities are actually more common than spirometric abnormalities. So spirometric abnormalities, what we use to diagnose COPD. I already told you that COPD is the most prevalent pulmonary condition in HIV, but yet diffusion abnormalities are more prevalent than spirometric abnormalities. So I'm like, strange. Because so many people have diffusion abnormalities and don't have abnormal spirometry, they actually have ISO-DLCO, abnormal diffusion with normal spirometry. And so in our clinic here and in our hospital and in our research study, ISO-DLCO is the most frequent PFT abnormality in our hospital here in people with HIV. So I came up with a new name. These are 4 published studies in the literature that document that diffusion abnormalities are more frequent in people with HIV compared to those without HIV. They all come from either the lung HIV study, which I was part of, or the MAX study, which was the Kunisaki 2020, or the Y study, which is the Huang 2023 study. So large, multi-center collaborative studies that did PFTs. People with HIV more commonly have abnormal DLCO than people without HIV. As I said, in our I Am Old study, we show that ISO-DLCO is the most frequent PFT abnormality in persons with HIV. This was led by Amanda Jan, who at the time was my study coordinator. Some of you may remember her. She's, I think, a 4th-year medical student now at UC Davis. But basically, the red arrow points to the individuals with ISO-DLCO by virtue of having normal spirometry, so above the LLN, but an abnormal diffusing capacity below the LLN. 34% of people, nearly as many as had normal PFTs in our cohort at the time, and higher than individuals who had abnormal spirometry, so COPD based on a post-bronchodilator FEV1 FVC ratio below the lower limit of normal. Okay. Katerina Bianova, who is a Pulm Fellow in clinic with me, so a lot of you have seen her for the last 3 years in clinic with me, took this a step further. We looked at the MMRC, the CAT, as well as the St. George's Respiratory Questionnaire, so another well-characterized, validated questionnaire to assess respiratory symptoms in individuals. And we showed, or she showed, that individuals with a moderate to severe decreased DLCO, so that's sort of the orange or red box on the far right for each of these 3 panels, was significantly associated with increased respiratory symptoms, either using the MMRC, which is the far panel, the CAT, which is the middle panel, or the St. George's, which is the far panel over there, compared to individuals with a normal DLCO. Okay, these were all individuals who had normal spirometry. So we cannot attribute their respiratory complaints to having COPD and an abnormal FEV1 FVC ratio. So normal spirometry, the only abnormality was diffusion, either mild, moderate, or severe. Individuals with moderate to severe ISO-DLCO, increased respiratory symptoms, all 3 respiratory questionnaires compared to individuals with the normal DLCO. Okay. Couple of background information slides. So abnormal DLCO can also be seen in individuals with emphysema, as you saw in case 1. And it's used to contrast emphysema from other obstructive lung diseases like asthma or chronic bronchitis, where the DLCO is normal. Abnormal DLCO is also seen in interstitial lung disease, where the total lung capacity is also abnormal. And we use that to contrast it to other causes of restriction where the DLCO is normal. So if the restriction is due to intrinsic parenchymal lung disease, the TLCO will be low, the DLCO will be low. If the patient has restriction with a low TLC and the diffusing capacity is normal, that typically argues against significant parenchymal lung disease, interstitial lung disease, and it argues for another cause of restriction. In the SFGH population, the most frequent cause of restriction outside of parenchymal lung disease is being morbidly obese. And therefore, they can't take a deep breath in. They can't get a lot of air in because of morbid obesity. Okay. Abnormal DLCO is also seen in pulmonary vascular diseases, including pulmonary hypertension, which we know is increased in people with HIV, as well as chronic thromboembolic disease. For these conditions, since it only affects the pulmonary vasculature, spirometry and lung volumes are normal. And lastly, DLCO, because it measures the ability of the lungs to transfer carbon monoxide, the CO in DLCO, across the alveolar capillary membrane to bind to hemoglobin in the capillaries. People who are anemic or people who already have their red blood cells, their hemoglobin bound with carboxyhemoglobin, usually from something like cigarette smoking, but could also be from poor air with a lot of carbon monoxide in the air. Those are other things that can cause a low DLCO. So if you have significant anemia, there's not as many red blood cells going across, right, with every heartbeat. And so therefore, it can lower your DLCO. As a sort of a minor point, we can also see a low DLCO early on in emphysema before the FEV1 FVC becomes abnormal, and early on in early interstitial lung disease before the total lung capacity becomes abnormal. Okay, so ISO-DLCO is a diagnosis of exclusion. We have a lot of patients in our clinic with ISO-DLCO, partly because we self-refer patients with ISO-DLCO in our research study to clinic so they can get evaluated because, you're short of breath, your DLCO is low, you don't have emphysema as far as we can tell based on PFTs. We need to figure out what's going on. And so it's a diagnosis of exclusion. We did a CT scan in this individual looking for early emphysema and ILD. We didn't find it. We also didn't find any other potential CT imaging finding that would explain the individual's chronic shortness of breath for 3 to 5 years. Pulmonary hypertension, I already told you, can be another cause for low DLCO. So we did an echocardiogram looking for pulmonary hypertension. Again, no evidence of pulmonary hypertension. So we thought this individual has ISO-DLCO. I could ask questions, what should we do now? The short answer is we don't know because we're not even 100% sure this is a specific condition, although we're definitely seeing a lot of it. So to be decided maybe with the next grant that I'd get. So in summary, I'm gonna finish exactly on time. Well, it's pretty good. PFTs are a cornerstone of the diagnostic evaluation of respiratory symptoms in persons with HIV. As I told you, the PFT, way we interpret PFTs has undergone dramatic changes. And I gave you the citation for the 2022 European Respiratory Society ATS guidelines. COPD is the most frequent pulmonary condition in persons with HIV in the United States. And I gave you a citation for the 2024 GOLD guidelines for diagnosis and treatment. In general, it's similar. I won't use the term identical in quotations. So it's similar to those without HIV. And I already gave you my personal recommendation when you're seeing somebody with sort of subacute respiratory complaints, usually shortness of breath, but cough would be another one. I would get full PFTs as part of their initial evaluation. And that's because DLCO abnormalities are actually the most frequent abnormality in people with HIV. They're more frequent than spirometric abnormalities. So if you only order spirometry like the GOLD guidelines, you're going to miss a lot of the pathology that our patients have. ISO-DLCO is the most frequent PFT abnormality. There's more to follow. I think many of you know that I'm known for my study acronyms. So because of the I am old study, which stands for inflammation, aging, microbes, and obstructive lung disease, we did that study, but we also measured DLCO. We realized from the Amanda paper, gee, DLCO abnormalities is really where the action's at. So for the renewal, I added the DA standing for diffusion abnormalities. So now it's inflammation, aging, microbes, obstructive lung disease, and diffusion abnormalities. As Nathan knows, we're about to write the I am older renewal. And so I've been threatening to call the next grant I am too old, which I think is more a comment on me rather than the mechanisms that we're studying. So thank you for your attention. Sorry the ARS didn't work, and I think I have 12 to 15 minutes for questions. Thank you. Annie.
Okay. Thank you, Laurence. Hello? Okay. Why don't you ask your question? So have you biopsied these people with
isolated DLCO? Like, what is your thought of what is actually causing this?
Can you repeat?
Yeah, so Andy's question is, have we actually biopsy these individuals? And then sort of the follow-up is, what is my thought for what's causing ISO-DLCO? So we don't typically biopsy them for this. We'd be looking for some abnormality in the pulmonary vasculature. I think we'd be a little bit worried about bleeding, but in general, we don't really do biopsies too much anymore. Yes.
Describe this new entity and we want to know why.
So we're building multiple grants based on this because no single grant can contain all the questions. So I'll go sort of in reverse order. So the I Am Gold grant, which some of you knew about, was a bronchoscopy-based study looking at people with COPD based on abnormal spirometry, ISO-DLCO, as I described, versus normal, where we did bronchoalveolar lavage as well as brushes. So not biopsy, but brushes to get endothelial cells inside the airways. And the two hypotheses related to that were that it's potentially related to altered lung microbiome, so a microbial thing. And then the second thing was that it was related to altered gene expression in terms of Th2. So that's a collaboration that I have with Prescott Woodruff and Stephanie Christensen over at Parnassus, where, as you know, they study COPD, mechanisms of COPD in people without HIV, as well as Sue Lynch and the Benioff Microbiome Center, who's been my longtime collaborator looking at the lung microbiome. The I Am Older grant, our hypothesis was that either it's related to immune activation inflammation, but then specifically within that, because one of my co-PIs is Peter Hunt, it's potentially related to CMV. And CMV in the pulmonary endothelium causing this ISO-DLCO. I didn't show the Amanda paper where we looked at specific markers of immune activation and inflammation. I could zip through it if people are super interested in it. I'm recognizing that most people are not researchers in pulmonary medicine, so maybe not interested, so I didn't show it. But this is one of the wow, life is full of great coincidences. So the first coincidence I'll mention, keeping track of the time, is that Peter and I had clinic on Friday afternoons for many years. And just like I was assigned to be your career mentor, Annie, I was assigned to be Peter's career mentor way back when. And so on Friday afternoons, when patients didn't show up, we'd sit in the conference room and we'd chat. And I'd be like, tell me about your research. And he's like, oh, this is banyan tree. I'm like, what's a banyan tree, right? But his thing about, immune activation, getting the root causes of disease. And so I started learning about it. And he's telling me about studies that he had with Priscilla and with Ma Samsuk and all these other individuals. I'm like, what about the lungs? The lungs never get no love in HIV, right? It's like, if it's causing problems in the brain and the heart, the bones, the kidney, the liver, it's causing problems in the lung, right? And so we started working together in I Am Old. For I Am Older, I was like, we don't have any ideas for the grant. What are we going to do? What are we going to do? What are we going to do? We're in clinic, rooms 1 and 2 together. Amanda, my coordinator, and Julia, my statistician, one day they come running into clinic. And they're like, we want to show you something. And they're showing me which biomarkers were associated with diffusion in individuals who had abnormal spirometry. So they had COPD and there were X, Y, and Z biomarkers. And they showed me that there were many more biomarkers and there were different biomarkers that were associated with diffusion in individuals with normal spirometry. So ISO-DLCO. Like, hey, Peter, come and look at this. And he's like, that's super interesting. The 3 biomarkers that were most strongly associated with ISO-DLCO are the 3 biomarkers that are most affected by letermovir, if I'm pronouncing that correctly, in his, I guess at the time, it was a pilot data, then became an ACTG trial. And so he's like, wow, super interesting. And so that started this CMV idea.
Very interesting. We'll have time for another question.
Thanks for a great presentation. I heard you say, if I understood you correctly, that people who desat on activity, probably most of them also will need oxygen at night.
Yes.
Right? It makes me. Okay, and it makes me think that there's a lot of people out there who probably should be on oxygen at night. And like a lot of people I know, only use a wedge pillow maybe at most. Is that something that we should be worried about?
I think everybody heard Guy's question, right? So the question was people, so I'll just sort of add to it. So people who are not desaturating at rest. So they just get a O2 sat in clinic, they're fine, but they desaturate during exercise. The point that I made in my talk was that these individuals should also be assessed for nocturnal hypoxemia. But your comment was potentially not a lot of them are, or not all of them are. That's something that we need to do. So when patients are referred to our clinic, we go through sort of the steps like I did in that case, right? The person's not hypoxic at rest. So we were kind of going down these different avenues, still short of breath, still short of breath. And so we did the walk test, right? You can order in the PFT lab, you can do it in clinic, but we do a 6-minute walk test in the PFT lab over in the basement of Zuckerberg. But if they desat during exercise, you should assess them for nocturnal hypoxemia, again, because they're more likely to hypoventilate. They're right at the edge there of needing it at rest as well, right? But it's only on exertion that they desaturate. It could be at night. And so you need to then get the medical supply company to hook them up at night just with the pulse ox, and they record it, and then they send you the report. So you can refer them to our clinic if